There we go. Okay, I have no relevant disclosures for this particular talk. So I'll be talking about CTEPH, or chronic thromboembolic pulmonary hypertension. And to think about this disease, if you don't think about it, you'll never make the diagnosis. It's a secondary form of pulmonary hypertension associated with underlying occlusive thrombosis. You need to have a high index of suspicion, and often these patients get misdiagnosed with other chronic lung or cardiac diseases. An important takeaway is you don't need to have a history of a DVT to develop CTEPH. So if you have somebody with pulmonary hypertension, always think of, in fact, if you have somebody with shortness of breath, think of pH. If they have pH, you need to exclude CTEPH. There's a lot of diagnostic strategies, and I won't talk about that today, but we do feel at UC San Diego that pulmonary angiography is critical to make the diagnosis and come up with therapeutic options. It's safe. We do it as a biplane procedure, and there are a lot of classic signs that you see on angiography, including pouch defects, webs and bands, intimal irregularities, and abrupt cutoffs. The reason we think biplane is important is here you can see the left lung. In the PA view, you see evidence of some disease, but not to the extent that you see in the lateral view, with a number of those arrows and circles identifying areas of high-grade stenosis or cutoffs. This is something that's not commercially available, but we do have it. We've stopped using it now because there are other better techniques. But this was an Olympus angioscope that we modified to evaluate the pulmonary arteries, and this is what you can see in somebody with CTEPH. So even if angiographically it doesn't look that severe, when you're able to look at it within the intravascular space, very much like IVUS in the coronaries, what you see are clots that have recanalized, so they look like chronic total occlusions, fibrous bands, and a recent publication from Japan showed something very similar with OCT. So another way to make the same anatomical diagnosis by using OCT or IVUS as opposed to angioscopy. The therapeutic treatment for this is really surgery. It's a big operation, takes 9 to 10 hours, complete cardiac arrest, and you need to actually cool down the brain for the entirety of the operation, which requires bypass for at least 2 hours. The data of over 3,000 PTE surgeries over the last almost 3 decades show that PVR comes down, mean PA pressures come down, and cardiac output goes up with the surgical option. And there are 4 levels of disease that are now recognized, level 1 through level 4, indicating more proximal to distal disease. The surgical outcomes are best for level 1, and they continue to decrease in terms of efficacy when you go out to level 4. So we won't talk about which candidates are appropriate for PTE surgery, but you can imagine if the disease is distal or they have a lot of comorbidities to tolerate an open surgery, they would not be good patients. Medical therapy-wise, there's only a single drug called riociguat that's been tested in a randomized manner for CTEPH, showing some benefit. So balloon pulmonary angioplasty, the first case report was 1988. The first real series was published in 2001 from the Boston Children's Group, and they were able to show that you can technically do the procedure, but the problem was at the very bottom. In 18 patients, they had 61% of patients had reperfusion pulmonary edema, 17% required emergency intubation, and they had a 6% mortality. However, they did report that symptomatic class improved in the patients. However, this study essentially killed the evolution or development of balloon pulmonary angioplasty until the very recent past. How does this work now? When you get out into the relevant segment, inflate a balloon, doesn't really involve stenting, and subsequently you're able to restore flow, as I'll show you in a case. The first contemporary series was published from Okayama, Japan by a gentleman named Hiromi Matsubara, and he published this outcomes in Circ Cardiovascular Interventions in 2012. 68 patients, 255 sessions, and as you can see on the right side, pretty dramatic improvements in pulmonary artery pressures, PVR, cardiac output went up. And so we saw this with very few complications, 6% intubation, 1 death, though they had 60% vascular injuries. So this was published in 2012. So in 2015, January 2015, that's the flight I took along with our team from San Diego to Okayama, Japan. We decided we better find out where this is and whether this is for real. So Okayama is way in the southern part of Japan. You fly to Tokyo and take a 3-hour bullet train. And this is Matsubara on the left side and myself with 2 of our pulmonologists that were there for a week. We came back and the technique as it stands today at UCSD is very different from what we started. Here's an example in a left lower lobe, A8, A9, and A10 segments in a CTEPH patient. Started off working on the A8, and I'll quickly go through the case. This is a 6 French guide catheter sitting in the A8 segment of the left lower lobe. In this particular case is a BMW guide wire with a 2O balloon, progressively dilated. That's the first segment opened up. Second segment of A8, that was in a false lumen, recannulated the true lumen. I want you to look at this because I'll show you the value of this. You see the wires buckling, and I'll show you later when we finally crossed how we decided how much to dilate here. We eventually get through. It's an occluded segment. Dilate that, dilate another segment. So sequentially went through A8, A9, and A10. This is what it looked like to start off with. This is what we finished with, that particular case. We're able to recannulate those 3 segments. The area where the wire was prolapsing on itself, when we eventually got through, we measured a resting pressure gradient using the assist system, in this particular case, a Navis catheter. And what you can see in the red is the proximal pulmonary artery. In the green is the distal pulmonary artery beyond the occlusion. We dilate it. The pressure gets better, still not adequate. We keep dilating until we have resolved that gradient. So our approach today at UCSD in 2017 to BPA is we don't no longer go with biplane angiography, we use single plane. We no longer use the internal jugular vein, we use the femoral vein, 8 to 9 French venous access sheath. Through that we put another 6 to 7 French long telescope sheath. Through that we put a 6 French guide catheter, which can be a multi-purpose Judkins or hockey stick. We do use the EBU for the lingula. We go with heparin. We've slowly lowered our heparin dose down to about 200 ACT. Contrast is cut 50-50. We use a number of guide wires. We avoid polymer jacketed wires because it's more association with reperfusion pulmonary edema as well as hemoptysis. That's been our experience. We use 2 to 5 millimeter non-compliant balloons. IVUS and OCT are rarely used, and we're using pressure gradients more and more so. On average, most of our patients get 6 sessions altogether. We batch up 2 sessions at a time. Everybody is getting a VQ scan, echo, pro-BNP, 6-minute walk test, and hemodynamic measures sequentially, and we admit them post-procedure for at least 24 hours. We used to put them in the ICU. We no longer do. The complications to worry about, hemoptysis is the big bad one. In our 150 cases, it's been 7%. Nobody's required to be intubated or any major vascular injury. Number of other issues that can occur. As time is of the essence, let me show you some of the preliminary data. This was published in Lancet Respiratory Medicine in 2014, showing 5 different groups. These are not number of patients treated, but number of actual procedures, 12 to 68, showing feasibility. Before and after intervention, the pulmonary vascular resistance clearly came down consistently in all of these studies. Another small group from Japan showing similar data. Quality of life indices improve after BPA. And this is, I would say, the most systematic published experience showing short term, that means 6 months, intermediate term, 6 to 18 months, and beyond 18 months, long-term follow-up of a series of CTEPH patients treated with BPA out of Tokyo. And what you see is short, mid-term, and long-term reductions in PVR. Cardiac index stays elevated, and mean pulmonary artery pressure is reduced. So at least one group is reporting fairly positive outcomes. We're in the process of putting our data set together and publishing it as well. Where do I think the field stands today? If you think about the pulmonary artery with disease in the proximal all the way out to the distal vessels, level 1 to level 4. Segmental is a subsegmental disease, so proximal is lobar disease, distal is subsegmental disease. Then we believe that the more proximal the disease, PTE, or the surgical endarterectomy is the preferred modality. The more distal the disease is likely the patients who have some benefit from medical therapy. However, there are patients who have not purely lobar, but segmental disease that might be perfect or ideal for angioplasty, and these are the patients who are probably set up for a randomized trial between pulmonary endarterectomy and balloon pulmonary angioplasty. So in conclusion, PTE surgery remains the gold standard for chronic thromboembolic pulmonary hypertension. You need to put together a team. This should not be done in a random, one-off manner. Somebody had a PE, shows up, you think they have CTEPH, you want to go and fix a lobe or two. You need to have a systematic approach between pulmonary vascular medicine, cardiac surgery, and interventional cardiology. You need to have experience in complex PCI. Patient selection for BPA is critical. And currently, the ones we're treating who are surgically inoperable have subsegmental or distal segmental disease. The ones who have undergone PTE and have residual disease, we'll also entertain treatment for them. There's a lot of technical refinements, lots of issues with respect to defining what the best strategy is. Every center has come up with a little bit of their own strategy, so we need to standardize some of it. By and large, I believe that this treatment has to be more physiology-based than anatomically based, although there's clearly a role for anatomy as well. So future investigation will focus on identifying optimal patients for BPA. We need to define appropriate endpoints. When do you stop? How long do you keep each session going? And what are the measures of long-term success? Those presently remain unknown. Thank you.